Thank you very much. I'll start off here with at least one question that intrigued me listening to Dr. Bull and Dr. Breer. And that goes to the principles. The principles obviously are U.S. based, coming out of the Belmont report, and I think that was a fair statement. But the question that I'm interested in is, are they generalizable enough to be applicable globally? Or at that level, do we need additional principles before we start going deeper? Is there something that we should consider other than the 4 principles that we've named? Or can we go with these 4 and, depending on how we describe them and develop them, they might be globally applicable? Dr. Bull, why don't you start first?
I think very much the principles are globally applicable, and you can see there is a great deal of consensus in various international guidelines like Helsinki. It's at the level of principle, it is very easy to be globally applicable. It's when you come down a couple of layers that the complexity arises. Okay. So I would embrace those principles, and perhaps it's paying that particular attention. I think in the respect you talk about that need for engagement. So how it's very challenging for a group based in one country to develop guidelines that are going to be broadly applicable. While I hope you'll get a very general response to your consultation, you may not get a huge uptake. It's quite a responsibility to respond from other countries. So it may be thinking how you can engage more widely, or what kind of framework you want to build into your principles that ensures that there is the engagement. So, for example, the study that we're looking at, sorry, I'll be finished in a minute.
That's fine, go ahead.
The study that we're looking at is, as well as looking at those tipping points, is to think how you can engage on a case-by-case basis, so that when you are setting up these categories, you don't have a complex granulated approach with everybody agreeing to different things, but how you can provide a framework that those accounts can be taken into place. And a similar issue is here is, what kind of consultation mechanisms may you consider are appropriate for determining how things arrive on a case-by-case basis. We have international guidance for research ethics, we have country-by-country guidance, so what might be a country-by-country derivative of appropriate data sharing principles?
So I'd say 2 things. One is that I agree completely with Susan, and it's not quite the Belmont principles. There's 2 important differences. One is that in the Belmont principle, there is no consideration of the benefit to society. There's no community public health goal. And I think that in this world of data sharing is a very important one to make explicit, and the public trust is also not explicit either. I do think those basic principles are reflected in the other common guidance, Helsinki, ICH, CIOMS, SIOMS, and others. I don't think that that's problematic, and I very much like the idea of getting community engagement in order to develop that as a forebearer of beginning interventional trials. I think that one of the frameworks that would be very important for you all to consider as a go-forward plan is a risk-based approach, so that the degree of consultation and of respect for persons is very sort of considered based on the risk of abrogation of privacy or confidentiality, and you'd have different potentially protections in place.
We talk a lot about benefits. It sounds like you want to adjust or balance a bit. We talk about risk, but it sounds like you're still
Yeah.
Here, all right. Good talk.
That's what I do for Jen. Does that, I am supposing that what you mean by this is that while we talk about benefits and risks, we seem to give a lot of weight to the benefits, and what you're suggesting is maybe we should reverse it?
Not reverse it, but I think it's a balance. And the risks are both in terms of patient confidentiality and privacy, but but also the risk of inaccurate secondary studies and the challenge that that will present, particularly if you're not comparing data elements that are similar across studies and you start to pool them because the data dictionary is inaccurate or the way that data is collected in India is quite different than it is elsewhere. So.
So I'd like to follow up on Pat's question about the international dimension and ask each of the three panelists to help us think through the point, Susan, you made, that agreement on the very broad principles is not nearly as difficult as when you drill down a few levels and get more specific. And I was wondering, you made some allusions in your talks to, for example, the HIPAA safe harbors just not being anything that means anything outside the U.S. Are there other examples you can each think of how, as you drill down from these very broad principles, for example, in consent, are there just different ways of specifying what consent means that really are different in various countries? And Phil, with regard to the role of journals and publication in enhancing public trust, are there different attitudes towards publication and the role of journals in different parts of the world as we implement that trustworthiness?
I think even though there may be some differences in attitudes and cultures, some of the same fundamental principles will hold. And I think as research in some of the emerging areas is becoming more prevalent, some of these same principles could be exportable to other countries that are beginning to conduct large-scale trials. So I see it more of a global opportunity to overlay some of these principles on consent in areas that are emerging with their trials. I think the issue of trust is important in various settings as well. Maybe a little more evident in some of the more developed countries, but in developing countries I think equally important. So I see that some of the principles here could be exportable to other settings as well.
The debate about universalism of principles and cultural relativism is very big, so I'm afraid I can only make a few comments and will therefore be misleading on what I focus on. With regard to consent, because you raised it specifically, there are different approaches that can be very challenging in a multi-centre clinical trial where you seek to apply a single consent process across multiple jurisdictions. On the other hand, if you take a malaria gen approach or other trials, you have perhaps the framework where you have guidelines for consent and fundamental issues that need to be covered in a particular way, and then that flexibility or the requirement that you then tailor it appropriately to the context. And there's a lot of support for tailoring consent processes to the context and very little advice about how best to do so. We're just required to do so. So it's somewhat ad hoc and variation in practice. To turn to the respect for persons and what the principle itself requires that engagement so that you can see what accounts for respect. People feel respect in some quite different ways, and it's a very difficult principle to pin down in the literature. And so it comes back to that idea of ensuring that you have appropriate local knowledge. With regard to the benefits and harms, one of the points I would like to mention, or the risks, is in addition to the privacy and the confidentiality and ways to ameliorate actual risks to people, there's the discussion about how people can feel wronged even if they're not harmed, even if they're not open to risk, because their data is being used in a way that they don't consider to be appropriate. And that is what we're trying to look at, what might be ways in which people feel wronged even if they're not harmed, they're not exposed to risk of identification. Your third point, the enhancing public trust is a huge responsibility. People place trust in clinical research or any other endeavour based on a huge range of information in a highly idiosyncratic fashion. And I wonder if a lot of the work you may want to do with trust is ensuring that it's a trustworthy process and the rigour and the transparency that's needed, but what might be factors that people appreciate as to feel trusted? Is it just the engagement, or is there some stake in the process, and at what stake do they need to be involved? And the final point was equity and justice, and that is, again, it's a very interesting point. We're already starting to see some variation between, for example, expat researchers and local researchers in a context, and it's often in relationship to power, about how equitably they feel treated in international research consortia, and that's across the whole framework. It's not just data sharing, but it does come down to acknowledgement and publications and appropriate frameworks. So again, that idea of equity, and particularly when you have stakeholders that are perhaps relatively poorly resourced or relatively powerless, when they're required to share data with better resourced centres, how, although the requirements are in place to appropriately acknowledge, there can still be concerns and problems arising, and particularly if we're also requesting researchers to appropriately support secondary analyses of the data. We heard about the huge costs of these managed processes, how those costs are going to be met in resource poor settings so that the data can stay within them, will again be challenges. So those are some of the areas where you may see some areas to address operationally as you drill down, but just a selection.
So I couldn't say it better, but let me just make a couple of further points. I don't think the principles are different. The application is very different depending on the setting. So, there are countries where the elders give consent. It is not the participant; it is the elder. And there are areas where women cannot consent to something that their husband does not know about. There are areas where homosexuality is illegal, and therefore, if there is something on, these kinds of details really do matter, and where the application of respect for persons, for instance, is going to feel very different for us sitting here than it would there when you see that being operationalized. I do think there are that my concern about coming out with sort of very American-based recommendations, as it were, is that, or developed country recommendations, is that many of the trials are globalized and multinational, and one really needs to think through how to incorporate the data across these platforms. But there is company in terms of groups that are thinking about it. I mean, obviously the EMA is, but I'm thinking of WHO may be a good partner, the Royal Society or MRC may be a good partner. There are various places that have thought about this as well, and getting some engagement may well be helpful.
Sorry. I wonder if you could help us. I listened to what you said, and it was an excellent presentation. You talked about asking for the same level of rigor for reanalyses as the original analysis, and even possibly pre-specifying and posting the protocol for the reanalysis. So what are your thoughts to us to guide us in our thinking in terms of the open access model?
I think the previous panel was very interesting in running the gamut of the fully open access to other sorts of models, and I think that the ability to carefully think out and anticipate a pre-specified approach is going to be very important for the success of data sharing early on. I could imagine investigators who've spent years collecting the data, thinking of the study, getting the funding, spending years of their lives, should be accorded the respect to know that those data are going to be looked at in a very thoughtful manner. I would hope that the shared data does not just devolve into a fishing expedition, as someone described it earlier, but that the use of the data should be meaningful and purposeful.
Just follow up on that briefly. In the meeting we had in October, we talked about this, and to go in with an idea suggests that you know what you're looking for. And quite often people want to have access to the data just to see what's there. They want to use it to generate ideas. And do you all feel that that's beyond the remit of what people have put into this? As an editor, I doubt if we would want to publish that, but as a researcher, you could see how it may be useful in fueling people's thought processes. So how do you feel about this as a guiding principle? Do you think that people will feel comfortable with having researchers paw through their data to look for trends that may turn out to be life-saving for other people coming down the pike?
I could see the entire gamut having potential value. I do think it still would be important to have transparency about what the intentions were. If the intentions were to call through the data and generate new hypotheses, that would be one intention, and that could probably be stated. If, on the other hand, there were specific ideas for reanalyses or new analysis, I think that could be stated as well. So I think the principle is to state the intentions of what the recipients of the shared data want to do clearly and unambiguously, and if that is only we want to try to find new hypotheses, I think that would satisfy that issue of transparency.
So, can I just comment on a couple of things? One is, I just to step back a second for this open access, I do think that this very much depends on what kind of data we're talking about. You talk about CER research, comparative effectiveness research, or pooling lots of data from medical records, and de-identifying and having a pretty good way of doing it, and not very sensitive data. It's very different than sort of first-in-man interventional trials, et cetera, et cetera. So I do think there has to be some consideration of the risk, and that's hard to say as a guiding principle other than there will be a body that reviews it. Investigators are loath to share their data usually, and want to sit on it for years, but some time certain I think is fair. I agree completely with Phil that and disagree with some of the other people earlier today. I don't think that one necessarily needs a hypothesis, a data analytic plan, and conclusion, and a publishable plan or a publication plan. That can be modified depending on what the goal of the study is, but it is still an approach that you commit to, an approach to say, I'm not going to publish it. That can be your publication plan. I'm going to do a fishing expedition. I'm going to do have my students validate the statistics. That's a plan, and that's how you're going to use it, and that's okay to me. And it would be reviewed, and it would be reviewed by a neutral body. I don't think it has to be hypothesis. It cannot be hypothesis generating.
That actually addressed most of my questions, was this notion of, sort of privileging requests for analysis that would end up in something publishable. Really is a very narrow set of use that we would probably want to support something broader than that, perhaps.
But just to be clear, I think that the publication plan should be should be clear
whether or
and
not
it's like
you're
a
going to publish.
Data safety monitoring plan. The plan can be, I'm not going to have one, it's such a low risk, but you have to put the thought into saying what it is and isn't. And then if you are going to sort of, if you do come up with a hypothesis that you now want to test in publish, you come back and say, this is what I found and this is what I want to do with it, so that you have transparency and accountability.
Thanks very much. I have a couple of questions. One is to get you, Barbara, to elaborate a little bit more on what you mean by compound authorizations, because that's a specific term of art in HIPAA, but I'm interested to hear and where you think the risks are.
So what I meant, not exactly the compound authorization of HIPAA, but similar drafting on that principle, where the informed consent, the principal question is whether or not to participate in a trial, but a condition of participation is a completely secondary permission to make that data, share the data. So that which again, if it's an observational study, it's different than if it's a therapeutic study that might be of benefit to the person. But if that is one of the conditions of participation, it seems to me not fair. It does not have the, sort of the fairness doctrine and the principle of respect for persons. And for the most part, if you want to have the impact of being able to do a reanalysis, you cannot have a tiered consent that allows certain patients to go in or participants to go in and certain participants not, because you'll bias the analytic, statistical analysis.
And then my second question has to do with the impact of transparency and how much we end up relying in many respects on transparency, whether it's to the data generators or to people seeking the data, but most importantly to the patients whose data is part of the trial, about sort of what they're consenting to essentially in a consent situation, or if we're trying to build public trust, how we're presenting to the public how the data is going to be shared. And it's something that's really hard to do well. So I'm wondering if you have any thoughts for us about how we can explore that aspect in a little more detail.
That is something certainly that our preliminary research suggests that drops out. People fundamentally appreciate the risks and benefits very well. They appreciate some aspects of the information you're giving them in extremely good detail. Certainly when you're working with populations with limited familiarity with computers and no familiarity with the internet, moving back to these rather abstract concepts of data sharing is complex to explain. Even with excellent methodology and explanation, it may not often be of interest, and people may choose not to engage with that part of the information that you give them. It doesn't mean it shouldn't be offered, but that awareness that it still often drops out of the information that's retained and engaged with. And so how to work when you've got that role, and the importance of trusted intermediaries in that situation where you think there will be some drop-off of understanding when it comes to methods and results of sharing. So it's to concur. We do have examples where people have explained that very clearly, but it's still not always of interest, and you often get, I won't call it a misconception, but you often get that primary therapeutic conception, and when people do consent explicitly to data sharing, there may be an explicit or implicit view that means that they're going to get the feedback of any ongoing research that's done from the results. There's an undertaking to feed back to them on an individual basis. So that's also often within the framework and needs to be engaged with.
So, we did a short study of about, I don't know how many consents to see what they said. And they sort of fell into four buckets. One was explicitly saying that data will not be shared, explicitly saying that data would be shared, consents that were absolutely silent on what the go-forward plan was, to which the PIs anticipated that would be fine then to go and share it, not exactly a transparent process, and then where the it was inconsistent. In one place it said it would not be shared, in another place it said it would be shared with regulatory agencies, et cetera, which most of us have. The interesting thing about looking and drilling down on that consent is that for the most part it says something like your data will not be shared, or your data will be shared with investigators studying the similar disease or something. And people have a range of understanding of what your data is, what that means, even if you don't go to resource-poor countries. We have a lot of public education that we need to do, and I think that's part of the enthusiasm for having a data use agreement that, at a minimum, sort of holds the data requester responsible for respecting the privacy, not contacting, even though we know that it's complicated.
I see no tent cards up. I want to thank all three of the panelists. You raised some really interesting questions, and you've given us a lot to think about in terms of how to operationalize these principles and to make them globally applicable. Thank you very much.